I'm Regina LaBelle. I'm the Chief of Staff at the Office of National Drug Control Policy, and thank you all for coming back after the break. We didn't scare you too much with the first hour and a half of the presentation. We, at ONDCP, always try to start with the science, which was what our first panel was about. Start with the science, start with facts, and look at some of the challenges and policy solutions. That will be the rest of the day. The next panel, we're going to talk about the policy and communications concerns. There are many policy and communications concerns, some of which you have already seen. This is obviously a very emotionally charged issue. The director and I went to a neonatal clinic in Washington State, and they had about 10 babies, and it was a very emotional experience for all of us who were there. We need to acknowledge that, but also need to, again, do this based on science and approach this very carefully. Because there are many legal complexities that attach to this public health issue, that's what we're going to talk about a little bit in our next session. And basically our premise needs to be, how do we step over the stigma to arrive at solutions? Our first speaker is going to be Steve Ondrusma, who is Dr. Ondrusma is a clinical psychologist and associate professor in the Department of Psychology and Behavioral Neurosciences at Wayne State University of Medicine. And he's on the faculty of the Merrill Palmer Skillman Institute at Wayne State. His primary interest is in brief computer-delivered motivational interventions for substance use and other risk factors. The former editor of the journal Child Maltreatment, a member of the Motivational Interviewing Network of Trainers, and has many NIDA grants that he's overseen for a number of years. So with that, I will introduce you to Steve Ondrusma.
Thank you very much, Regina. I'm very glad to be here and to talk with you about this. I've been working in this area since the start of my career, and my first major grant was from the Abandoned Infants Assistance Act of 1988, which came into being specifically because of the rise of prenatal drug exposure and as a response to that. And I worked to provide comprehensive services for mothers of drug-exposed infants. I've come a long way since then, as you got a hint from in Regina's introduction about computer-delivered interventions. I'll talk more about that this afternoon. But in the meantime, I just want to emphasize something that's been touched on already this morning. Ever since I got involved in this area, I've been struck by its complexity, its controversy, and what has appeared to me to be the almost complete lack of a consensual, evidence-based, agreed-upon, appropriate response to prenatal drug exposure. So I'm going to talk a little bit about that and some of the research that I've done in this area, so blending policy and research here. And in the process, in looking back, I hope to provide a context for some of the new challenges that we're talking about today. So first, in terms of a little bit of history, prior to the 1980s, in terms of big policy discussions and big responses from child welfare, from the courts, etc., there was very, very little. Even though there had been research for a while on the effects of drugs like marijuana during pregnancy, and especially alcohol. In 1981, the Surgeon General published the first warning suggesting that women limit alcohol use during pregnancy. But that was as far as it went. It wasn't a great, big, huge media explosion public discussion. The 1980s happened, and in particular, a report in 1985 in the New England Journal of Medicine, a report suggesting that prenatal exposure to cocaine might be extremely damaging and perhaps have lasting effects. Follow-up studies showing other sorts of negative effects. This led in a very short time to an amazing response from the media, from legislators, from the courts, from prosecutors. It became a social issue. And why it happened here, why it happened with cocaine and not with alcohol, not with marijuana earlier, or the early research on amphetamines, why that happened is a bit of a mystery. There are a number of reasons that I can't get into. You may get a little bit more of that from Ms. Paltrow in a moment. But suffice it to say that it was big. By the early 1990s, a special issue in the Journal of Neurotoxicology and Teratology, scientists were urging a lot of caution, saying that the early studies were methodologically flawed, that there were a number of studies suggesting that the effects were not nearly as bad as had been previously assumed, and urging that we really step back on the really strong social policy kinds of responses. It was a message that worked with scientists, but the cat was out of the bag in terms of the policy responses. Big study came up also. The maternal lifestyle study was initiated in the 1990s, designed to address the flaws, led by Barry Lester, multi-site and longitudinal study, extremely well done, beautiful use of NIH funds. Found later on in the 2000s that in fact the results were not, the effects of cocaine and opiate exposure during pregnancy were not nearly as bad as been previously assumed. Longitudinal studies were showing that the effects were subtle, they were very real, and they shouldn't be ignored, but they were subtle and not unlike those of tobacco and possibly less than those for prenatal exposure to alcohol. I'll talk more about that in a moment. Which brings us here, but in the meantime, in the 2000s, still policies were coming out saying that infants born affected by exposure to drugs had to be reported to CPS. Laws all over the place in terms of what to do. Which brings us to now, with the rise of prescription drug abuse and brand new issue, and it's going to be interesting to see how child welfare and the courts respond, and I think we'll hear a little bit more about that from Ms. Paltrow as well. I was so struck by the lack of guidance in the area when I was first starting out and felt so insecure about what we were doing in my program. I really wanted guidance, so I decided to just do a survey as well, much like Ms. Harrow. I talked to 4 intake supervisors from 4 counties from every state in the country, asking them how they handled reports of drug exposure in their county, whether they even got reports for those. So 2 urban counties in every state, 2 rural counties in every state, asking them how they handled this, hoping to get some sort of guidance, some sort of consensus that people felt good about. The scientific term for this, I think, is the beach ball effect. Okay? Every possible response was equally represented, both in terms of substantiating a case, so becoming formally involved as Child Protective Services, and also in terms of taking custody of a cocaine-exposed infant. We were likely to get a response of, never, why, to, of course, why wouldn't we? Right? So absolute lack of consensus there. So the question is, why? Why is this so hard? Why is there such a lack of consensus? As quickly as I can here, I'm going to offer 5 possible reasons for that. There are many, many other possible ones. You'll probably hear more today. I'll go over a few that I think are important. One that I think is particularly important is the lack of context. It all depends on what you look at. If you're only looking at illicit drug exposure, which is the 4.4% over there, these data are from a major national survey of drug use amongst Americans. And this is specifically drug use during pregnancy. About 4.4% of women are reporting using illicit drugs during pregnancy. A much higher amount are using alcohol during pregnancy, and a much higher amount than that are using tobacco during pregnancy. And what we know is that tobacco is equally unsafe during pregnancy. It's equally as likely to result in negative birth outcomes and long-term sequelae, and alcohol is almost certainly worse. So if you're focusing on drug use, and even within that, focusing specifically on cocaine use, as in the past, or methamphetamine use, which is the next wave, or whatever the new wave might be, you're going to see things really differently than if you're looking at the bigger picture. And this goes as well for other issues. That's just substance use on this slide. Lack of prenatal care, exposure to environmental toxins, poverty, lack of access. There are a great number of factors associated with negative birth outcomes. So your response on this is going to be dependent in large part on whether you're looking at that great big picture or just at one piece of it. Second reason, I think, is lack of humility in terms of what an appropriate response might be. I give talks on this often to child and family court judges, to child welfare professionals. Even very recently, when I talk about the more nuanced research results in terms of the effects of prenatal exposure to drugs, the response is absolute and utter shock. They are blown away. And then secondly, among a subset of these folks, the next response is hostility. They are furious with me for daring to suggest that illicit drugs might not be devastating because they know they are. This is a real challenge to moving ahead based on research results. Third, perspectives matter. No one wants to see this. No one wants to see a child exposed to anything that might harm them. And I don't blame anybody for not wanting to see that. At the same time, what for one person is criminal conduct or a clear moral issue, to another person is simply a public health issue that we need to respond to in the same way that we might respond to, say, prenatal or postpartum depression. Right? So how you look at this matters a great deal in terms of what you think the ideal response might be. And whether or not it's maltreatment, this gets thrown around a lot. Is prenatal exposure to substances by itself child maltreatment? If it is, why isn't tobacco exposure by itself maltreatment? There are a lot of discussions about this. The one thing everybody fortunately agrees on almost universally is that identification and treatment are important. And I, of course, couldn't agree more. But there are a couple problems with that have made things even more difficult. And I apologize if this sounds a little bit doom and gloom. I'm a bit more optimistic in my afternoon talk, I promise. Okay. The first thing that makes identification and treatment a challenge is that they don't want us to know. And we've touched on this very clearly already in the morning. We've done research in which we randomly assigned women to either be told this is an anonymous survey, we won't collect your name, we don't know who you are, do you use drugs? Versus, we're not going to tell anybody, we promise your name is, okay, thank you, Ms. Doe, do you use drugs? We're a little better than that, but you get the idea. Okay. 14% of women in the anonymous condition said, yep, I've done drugs, and 2% in the non-anonymous condition. And this is when we were swearing we weren't going to tell anybody because this was research. Right? They don't want folks to know. And that really limits our options in terms of identifying and treating them. The second thing that matters is that even when you do know, most of them don't get treatment and aren't interested in it. Of the 23.1 million Americans who are in need of treatment for drug abuse or alcohol abuse or dependence, 85% have neither received any treatment in the past year nor are interested in it. Among women involved with child welfare, I'm getting a red light. Among women involved in child welfare who are ordered to get treatment, 22% complete it in one fairly recent study. Okay? Treatment is incredibly important. We need to make it available. We need to make it good. We need to make it sensitive. We need to make it accessible. But it's not the only thing if we're going to address this large untreated and unidentified majority. So quickly to wrap up, responses all over the map. A message of it kills babies goes over really well and is stickier than a message of, well, there are subtle deficits that are sometimes seen and not seen, and you have to compare it to other sorts of factors. Right? There are a lot of barriers to a good consensus in this area, and it's a real challenge to identify and treat folks. And I'm especially interested in that last part, those unidentified and untreated folks, and how we can access them and hopefully promote treatment or change. And I'll talk about that later. Thank you.
Thank you, Dr. Orange-Smith. Our next speaker is Lynn Paltrow, who is the founder and executive director of National Advocates for Pregnant Women. Ms. Paltrow is a graduate of Cornell and NYU School of Law. As executive director of the National Advocates for Pregnant Women, Ms. Paltrow combines legal advocacy and grassroots and national organizing on a number of issues relating to women's rights, the rights of pregnant and parenting women, and other vulnerable populations. Ms. Paltrow frequently represents leading medical, public health, and child welfare organizations and experts, and has written numerous articles. Thank you, Ms. Paltrow.
Thank you so much for having me. I often do have the privilege of representing leading medical public health organizations and experts, and do so because they are concerned that when they are concerned that policy, judicial decision-making, and media are ruling and reporting based on stigma, not science. As much of what I'm going to say, I'm very grateful, has been touched on. We can look back at what happened. Wait, I guess I went the wrong way. Here we go. We can look back on what happened as a result of initial reports around women using a smokable form of cocaine. It was associated particularly with low-income African American women, which in part explains a rush to judgment that resulted in wild claims and characterizations of women and children in ways that, that many believe hurt all maternal, fetal, and child health. If you have innocent victims, somebody has to be guilty, and you've created a context in which punishment seems like the most likely response. You've seen very overblown reaction, and you had a variety of responses from the reporting, the inaccurate reporting, that included some measures that involved increased treatment and research, but mostly punishment. We've documented states which have arrested pregnant women. 47 states and prosecutors have arrested pregnant drug-using women. This is not because the states, in fact, have listened to the researchers on this issue. No state legislature has passed a law making it a crime for a drug-using woman to go to term. So why are these arrests happening? They are happening at the confluence of, for lack of better phrasing, the war on women and the historical war on drugs. For example, Alabama has a Child Chemical Endangerment Act that was passed to create special penalties for parents who bring children to methamphetamine labs. It was specifically rejected to create a special crime for women going to term in spite of a drug problem. However, prosecutors are arresting over 60 women who've given birth and tested positive for any controlled substance based on the interpretation of the word child, the argument that a child should be viewed as a fertilized egg, embryo, and fetus. So the medical groups have spoken out against direct legislation that threaten to create penalties for women going to term with these problems. But when they have not been able to or realized that responses to legislation like feticide laws that are used to justify arrests of women going to term. We also see many states and the federal government equating a parent's drug use with a civil child abuse. And we saw the experience of these children, or the reporting of these children, resulting in extreme laws and disproportionate penalties. So we saw women like Kimberly Hardy and Britta Smith, who looked through the yellow pages for treatment, told that there were waiting periods that she couldn't get in, but there was no waiting period to be charged with child abuse in Virginia. Families and people literally at Medical University of South Carolina taken out of the hospital in chains and shackles, subject to secret searches. And where, for at least low-income people, weren't accessing treatment, they were getting imprisonment. So what happened? We finally got research. People started to listen. There had to be some kind of corrections. The New York Times, the Oklahoman, and many papers across the country finally start running stories about the epidemic that wasn't. And you have federal agencies saying, wait a minute, we all did make a rush to judgment. Much of this was exaggerated. And you had to have administrative corrections or efforts to ameliorate extreme measures taken in part with the justification of protecting children who were harmed, but in the same way we might expect threatened with harm or harmed by the same way that smoking cigarettes, as we've heard, would do that. What's the current media response? Media does not tend to contextualize. So if you're planning on writing a report, expect that your findings will be articulated in the most alarmist way. There are many risks to children, many risks pregnant women experience. And numerically speaking, use of illicit drugs is among the least of all of the factors that can influence pregnancy outcome. And that doesn't include environmental hazards, which are finally receiving more attention. The media uses the term drug-addicted newborns, even though leading researchers say that addiction is a technical term that refers to compulsive behavior that continues in spite of adverse consequences. By definition, babies cannot be addicted to anything. It is a stigmatizing term. And it also, we have reporting that defines women and not as addicts, even though DSM-4, the Diagnostic Statistical Manual, distinguishes between drug use, abuse disorders, dependency, and addiction. These distinctions are not generally made in the press, and the result is a highly charged, not science-based approach. The media infrequently cites or refers to experts or the range of experts in the field. For example, they are more likely to ask the opinion of a local pediatrician, not a researcher who has spent years doing the work, and they often don't contextualize. So today you heard about research that says if you keep babies with the mama after birth and you allow skin-to-skin contact and breastfeeding, the babies do better. The need for medication may be less. That I have seen is not reported anywhere. You also have very stigmatizing words like the tiniest victims. Now, this is a way of describing pregnant women. It seems very odd to me, and we should have concern for that. Many of the women who have given birth to newborns that are exposed to drugs or have been exposed to the medications they've been given during pregnancy are women who've undergone cesarean surgery, they've gotten prenatal care, they love their children, only to find out that their giving birth to a beautiful newborn child is described as some form of victimization. It's very selective and a very odd way to think of pregnancy. And it's selective in the sense I've given two alternatives. When women take fertility drugs and don't selectively reduce, they pose a risk of harm if they're carrying multiple embryos. In this story, the woman was pregnant with 7 babies, one of whom was stillborn, one of whom has severe disabilities. Her babies are called little miracles. In the bottom picture, you will see a woman holding a red-headed baby with a cigarette in her hand. That woman smokes cigarettes all through her pregnancy. That baby is called Lynn Paltrow. And it may be your name because we don't characterize or call people, describe them as victims, creating a conflict between the needs of children and the needs of mothers. We can't fix anything if we don't see them as the unit that they are. The media is also very quick. Anderson Cooper happened to do a show about the day that Dr. Patrick's research came out. The poll that they posed to people was not, should we make more treatment available? Should we ask women or Americans, why are they using pain meds? What kind of pain are they in? That would be a good research question. The question was, should we start arresting women? And his suggestion to one of the brave women who was in treatment, who was on the show, was, couldn't you have done something medically, surgically, to stop having children? So the suggestions focus on punishment, sterilization, and not the barriers to care. Our government has produced brochures that urge pregnant women to use methadone treatment. There are regulations that make methadone clinics give pregnant women a priority. Yet, we have not enough treatment. We have thousands of people who would benefit from methadone treatment who can't get it, 4 states that do not have a single provider, prisons that force even pregnant incarcerated women off of successful methadone treatment. These are issues, policy issues that need to be addressed. And maybe what's the worst of the new media coverage is it's not only a familiar, alarmist misuse of term, it is actually much of the reporting suggests that obtaining the federally recommended methadone treatment or any other treatment is itself a form of abuse. So that they ask this woman in the narration on NBC with Brian Williams, who begins the show by reiterating and restating the false claims about the crack epidemic, whether she feels guilty to have caused her child suffering because she did what the federal government asked her to, got into methadone treatment, gave birth to a child, no illicit drugs, and a treatable condition at birth. What needs significantly more research is that there are not just barriers in terms of lack of funding for treatment, for methadone treatment, in addition to the family-centered treatment you'll hear more about, But we have absolute, I'll give you an example. Around the time that Dr. Patrick's study, and he teaches, I believe, at the University of Michigan, came out, we got a letter in my office, and I realized I'm going to be telling anecdotes. But we are collecting these and hope that we can combine with some of you to document these and look at how widespread this is, because our experience is there is an epidemic of barriers to treatment for pregnant women. This letter came from a woman in Michigan saying, we provide methadone treatment. Our patients are doing what they're told, they're using methadone, they're off street drugs, and judges and child welfare are reporting them as child abusers and telling them that they can't breastfeed. In New Jersey, the picture of the woman there, she had a rough life, a long history, finally gets into drug treatment, does the methadone treatment, is not using any illicit drugs, she gives birth, child welfare comes in and takes that child away because she was in methadone treatment. And child welfare courts, overwhelmingly, and I believe this is easily documentable, make rulings without any science. When a pharmaceutical drug company is accused of giving a woman a drug that might cause harm, they come in and say, wait a minute, you don't get to go to trial. This is the Daubert case for any of you lawyers. If you can't provide us with an expert that can show, as a matter of science, that the drug is actually causing this harm. Yet in family courts across the country, a caseworker can come in and say, this woman tested positive, that causes harm, and that's it. No requirement of scientific evidence of any kind. And this was a rare case where Dr. Loretta Finnegan, Dr. Robert Newman testified about the science, and the judge, in one of the rare opinions, said, wait a minute, this woman did what she should do. This baby got the care it needed from her, and we should be encouraging this, not removing children from women like this. 3 states have civil commitment laws that create a possibility of civilly committing a woman who's using drugs, and in some cases alcohol, with very few procedural protections. A woman in Wisconsin went to the hospital to get care for her opiate addiction. While people in one part of the hospital were setting up treatment, the others were calling the police and social services under the civil commitment law. She was removed from the hospital, taken 2 hours away, put in a locked mental ward where she received no prenatal care. So the assumption that testing and reporting or statutes that give people that put people in care institutions does not necessarily mean they will get care. What does science have to do with all of this? So I do have a little bit of an illustration. Very much of what's going on in this country, and you've heard some suggestions that we need more of this, is based on drug testing. So my family complains about this, but I do carry this around. This is, as many of you may know, a familiar thing. It's a urine sample cup. And I can tell you that a urine sample can tell you, if it's done well and done accurately, that a person has used drugs within a certain amount of time. It cannot tell you whether the person is actually dependent on those drugs or addicted to those drugs. It cannot tell you how often they use that drugs, and it absolutely can't tell you whether they love their children or are able to care for them despite whatever problem they may have. You cannot use this test as a substitute for what we also have very few standards for, an evaluation that is the key one in child welfare. Can this person adequately parent? Not do they still have a drug problem, not any of the other things that are assumed. Let me just talk about several things. Drug testing in the United States of America for pregnant women. A TIP panel, a federal panel, some years back in the 90s said they didn't recommend it particularly, but if hospitals chose to do it, they recommended that they do it according to federal workplace regulations. And the fact is that there is less regulation of testing for pregnant women than there is for applicants at the hospital. There is no research establishing medical criteria for, there are medical criteria used for testing, but actually there are no studies that establish them in the first place. They're called medical criteria. Studies have found that they are not better at distinguishing than others. And we also know that there is studies that these testings are often biased. I see the red light. Let me just conclude with a few points. Policy focuses on punishment, despite knowing that Threatening women with punishment, including losing their children, deters them from care. We actually have very little research actually showing a causal link between drug use and child abuse. The most cited study is ACASA. It's not a study, it's an opinion survey. Many of us in this room are old enough to have experienced or may have used an illegal drug, and you know that taking that drug did not cause you to beat your kids or leave them out in the cold. There has to be a much more sophisticated look. We don't, although we've put many things into place in terms of testing and reporting, very few studies. This is not a peer-reviewed study. Arkansas is the only state that has even bothered to look, as far as I can tell, about what the impact has been of the reporting. What we need to do, we need to put a sign up in every prenatal care clinic. If you have an opiate addiction, tell us. We will give you non-judgmental, affordable treatment. Prenatal care providers should be trained and encouraged to get waivers so they can provide buprenorphine. We need to make sure that women are not treated as second-class status in terms of informed consent and the accuracy of the drug tests that are given to them. And we need to make sure that we have a society in which, when we talk about children and the sanctity of life, that we are very clear that we value the women who give that life. Thank you.
Any questions that anyone has for the panelists? I want to know how she got through security with that. Well, I'll start, and if you want to come up here and answer the question. You talk about identification and treatment, and I'm sure this is connected to the stigma piece, but how do we, treatment, it is not uncommon for the majority of people who need treatment not to seek it, including pregnant women. How do we first encourage more pregnant women to seek that treatment and get that early identification? And then lastly, Professor, Doctor, since you work on technology issues, I don't know if you have an opinion on the prescription drug monitoring programs and how they can be used to do early identification and referral to treatment for women and their children.
I can be quick about the second question regarding prescription drug monitoring. I just don't know anything about it, so I'm afraid I can't address that. I'm in a kind of a very different part of this whole field. In terms of encouraging identification and treatment, you're absolutely right. That's true everywhere, not just within pregnancy, but it is worse during pregnancy. Pregnant women are less likely to report substance use and therefore to receive treatment than folks who are not pregnant. I think we have to do a few things. One, we have to be proactive. We can't wait for them to come to our attention from some method other than going out and finding them. And the best place to do that is in healthcare. So universal screening, universal self-report screening within the context of as much safety as you can provide. You saw my slide on the huge difference in self-report depending on the context in which you asked, not to mention the way that you asked the question, whether or not you do so using an evidence-based screener, for example. So step one, I think, is to make it safe to talk about. In that context, you can currently, as far as I know, go and get treatment for drug abuse anywhere you'd like to, and it's safe. They're not going to call the police, and you won't end up getting a court involvement as a result of seeking treatment. That's less true with prenatal care, and we need to change that. Then second, in terms of treatment, is we need to think of it more broadly. Ideally, everybody would get good, comprehensive, sensitive, coordinated care. I would like to see that for everybody, but it's not going to happen anytime soon. So we need to also think clearly, as Tom McClellan has said in the past, we need to think about our audience and what they want in terms of marketing. If they'll only accept a few brief sessions, let's do a few brief sessions. We can try to get them into more intensive treatment in the process, but if they won't, at least they've got something. And the data on what brief interventions can do is actually somewhat surprising, and I'll talk more about that this afternoon. Thank you.
I'll address the first question, which is about getting women to seek care. And I just have to reiterate that there is another side of it, which is what are we doing about the women who are seeking care and are being told by judges in Kentucky, New Jersey, Tennessee, Michigan, Texas, that if they are on methadone treatment, their children will be taken away from them. So we have two problems. We have people who are afraid to seek treatment, maybe don't know how to ask for treatment, and we have people who are in treatment programs who are being told by family court judges and probation officers that the very treatment the federal government recommends will result in them losing their right to parent and provide the best and safest care for their children. I don't really want to be the controversial person, but clearly we've heard the word stigma used a lot, so people who are stigmatized are scared to talk about things. We also know that when something is criminalized, when something is overwhelming the subject of a criminal justice system, it not only results in stigma, it also makes people afraid to talk about it. So we can't discount that reality in terms of our efforts to try and help pregnant women and children. And I think the thing that would absolutely reduce the problem, well, I'll give two things. One, if we were able to convey to in every prenatal care clinic, we will not remove your child or threaten removal or subject you to overwhelming state surveillance if you can provide adequate care to your child. If you tell us you have a drug problem and you can provide adequate care to your child, we will help you with that drug treatment in the way that makes sense for you and your family. People sometimes don't seek treatment through public systems because we essentially do have a caste system. For people who are ordered into drug treatment through child welfare systems, they have to give up one of the things I count on in my treatment, and that is confidentiality. You have to give up the ability to decide that maybe this counselor isn't the right one for you and isn't helping. You lose that. So you have a very different set of systems for some people, and we have to make that treatment. If it works for me, then it should be applied to everyone.
Do you have a question?
Sure. I'm Jean Mahoney from the American College of Obstetricians and Gynecologists, and it's great to be here, and you guys are my champions over there. But I have a question about CAPTA, which right now is looming high. CAPTA is a law that came into effect in December of 2010, and really it's a child protective law that on the surface looks very good, but when you get down particularly around the issues of substance abuse, it's becoming a real issue. And we're looking at states that, and states are given money to their child protective services to enforce the CAPTA mandate, which is that any child that has exposure to any drug during pregnancy needs reporting to child welfare. That would include marijuana, that would include any sip of alcohol, and that would include, of course, opioid drugs. And I'm not trying to stand here, but I know that many states are really looking at, I'm going to lose those dollars that are really important to me because my child welfare system really needs that money if I don't enforce all of the regulations of CAPTA. And so I'd love to hear what you think.
So Jean's referring to CAPTA, the Child Abuse Prevention and Treatment Act, which was recently updated under the Keeping Children and Families Safe Act. And it does a few things. As she said, one, it mandates states, if they want to receive this funding, they have to develop policies and procedures for prenatal substance exposure. And two, they're required to report when an infant is born, and this is the way the language is phrased, affected by exposure to illicit drugs or in withdrawal from illicit drugs. So this language is interesting. In terms of withdrawal then, that's certainly going to weight it towards opiates and prescription drug abuse and such. In terms of other drugs, I don't know how anyone interprets this. How do you know when a baby has been affected by cocaine, when that, first of all, babies look bad sometimes for all kinds of reasons that we just don't know. Second of all, that baby almost certainly was exposed to tobacco and alcohol and cocaine as well. How do you know which it was? So I'm not sure how to do that. But the other thing that's important about that act is that it mandates reporting to Child Protective Services. It doesn't mandate that Child Protective Services necessarily do any particular thing in response to it. So what I would love to see, and I don't know how realistic this is, I would love to see, to the extent that we have to follow it, and it's that affected by clause, which may give a lot of wiggle room there, certainly less so with the withdrawal. I would like to see CPS not necessarily believing that they need to take the more coercive approaches. It's relatively easy for states like Michigan that has something called differential response, in which they're able to come in and simply make services available for some cases. That would be a good way to go with that. Does that help?
Just historically, it's my understanding that there actually were no hearings preceding the adoption of the amendment to the Child Abuse Prevention and Treatment Act. So it's a very good example of the need to bring science to policy. And language is interesting too, because the statute does only require reporting of drug-affected and newborns and newborns who technically have been diagnosed with NAS. But as you've heard in the language, it first said drug-exposed children. So I know from consulting in New Mexico that doctors and hospitals routinely just use a positive urine test, not confirmed, not done according to the standards for workplace testing, and report that to agencies that are filled with people who get most of their information not from scientists, but from Newsweek and Time and NBC News. The American College of Obstetricians and Gynecologists, one of their committee statements, has looked at the results of fear of reporting. Sarah Roberts has done research on it. And I think it's time to go back and say, is this a law that is actually protecting children rather than destabilizing families and putting resources into a kind of surveillance where it could be going to family treatment and methadone treatment that are needed by people rather than just because there's a positive drug test.
I am Rob Morrison, National Association of State Alcohol and Drug Abuse Directors. Thanks, Phil and DCP, for putting this on. I also want to recognize the work of the Center for Substance Abuse Treatment. They've been working collaboratively with NASDAD and our component group, the Women's Services Network. I know we'll hear from Sharon Amatendi. She's been fantastic, so thank you, Sharon. Quick question on messaging. I know folks in this room cringe when we hear the stories that we saw about the messaging about babies being addicted. But has work been done to do some surveying on terms that are helpful? As I think about the work I used to do on Capitol Hill, walking into staff, and we have a laboratory right here with staff members, if I went in to try to explain the difference between exposure, abuse, dependence, use, and addiction, the 5 minutes I have with staff are lost. So have we done any messaging, polling, to find out what does and doesn't work to help the field then do a better job to make sure we educate in a way that people who are lay folks understand? Thank you.
Maybe you know others. I don't know of any polling. I do know that we have so much history that we can anticipate what's going to happen. So a 1990 report on drug-exposed newborns gets repeated recently as a report on drug-addicted newborns. I think we do know that exposure and technical words work, and that when we conflate drug use with dependence and addiction, it hurts people. And I don't think that takes 5 minutes.
Yeah, I would just echo that. I think exposure is a quick term that works reasonably well. It is at least less loaded than addicted. And also that there is research on this. You may remember famous studies on the Pygmalion effect. You tell teachers that this child is struggling and this child is likely to do really well really soon. And they get treated differently, and they get treated differently in a way that actually leads to different sorts of learning. The same has been shown to be true with cocaine-exposed infants. When folks are told this is a crack baby and you can expect trouble with this, trouble actually happens. That doesn't happen when they don't have that label. So difficult issue and how to message this. I would suggest just exposed, and if your time is limited, leave it at that. Thank you.
Raise your hand if you have additional questions for this panel that you'd like to submit in writing.
Thank you very much. I think the last question was good in terms of words matter. I think that's one of the things we've heard here today. It's also something that at ONDCP we try to use the right words that are science-based. And very importantly, just the word addiction generally, and making it about substance use disorders, and you lead with the individual, not with the disease that they have. Thank you very much. We have lunch now, which it's downstairs in Ike's. It's on your own, but you can avail yourselves of the great EEOB cuisine. And we have to be back here at what time? 1:15. Thank you very much.